You know, um, when you think about a cancer diagnosis, the narrative we're usually sold is, well, it's pretty universal, right? And it's heavily biased toward immediate action.
Yeah, absolutely.
Well,
Blast it right away.
right. We find a tumor, and the instinct is just to eradicate it. I mean, the patient wants it out of their body yesterday, and the physician wants to hit it with everything in the arsenal. Action is just the default. It feels safe. But what if I told you there's an entire category of rogue, potentially malignant cell clones just hiding in the bone marrow of millions of older adults, and our absolute best medical advice, like the gold standard of care, is to just stand there with our hands in our pockets and watch?
I mean, it is deeply counterintuitive, and honestly, it's one of the hardest conversations to have in a clinical setting.
Oh, I bet.
You're essentially telling someone, you have a premalignant clone of cells. We see it, we measured it, but treating it right now would actually cause you more harm than good. That restraint, that precise understanding of when a disease is idling versus when it's actively destroying the body is really the absolute crux of what we're dealing with today.
Welcome to Evidence at the Bedside Board Review Edition. I'm Dr. Taylor, your host, and as a clinician who loves unpacking these incredibly complex medical mysteries, I am so ready to get into the weeds. Joining me is Dr. Griffin, our resident expert and analytical guide for this session.
It's great to be here. We have a massive mission for this deep dive.
We really do. We are exploring the diagnostic muddy waters of plasma cell dyscrasias. This is a spectrum of disease that starts with those completely benign incidental findings like monoclonal gammopathy of undetermined significance MGUS and ramps up all the way to active multiple myeloma, plus those critical multi-organ cousins like AL amyloidosis and Waldenström macroglobulinemia.
And if you're listening to this as part of your preparation for the ABIM Internal Medicine Board exam, or really any advanced medical certification, you need to mentally flag this entire deep dive.
Oh, for sure.
The exam writers are just obsessed with this topic.
We really are. It feels like every practice test I've ever seen has at least 3 questions rooted in this exact pathophysiological neighborhood.
Right, because it's the perfect testing ground for a physician's diagnostic reasoning. It doesn't just ask you to memorize a drug name.
No, it forces you to think.
Exactly. It forces you to demonstrate that you know exactly when to pull the trigger on an invasive procedure, like a bone marrow biopsy, and exactly when to observe. It tests highly precise quantitative cutoffs, and most importantly, it tests your ability to anticipate dangerous management pitfalls.
Yeah, they love a good pitfall.
The boards love to see if you'll cause, iatrogenic kidney failure because you carelessly ordered the wrong imaging study or the wrong medication for a patient whose kidneys are hanging by a thread.
So before we start pulling apart the biology, let's look at how this actually shows up in the real world and, on the exam. Because patients don't walk into the clinic carrying a neat diagram of their bone marrow.
That would be nice, but no.
Right. They present with vague, frustratingly common complaints. So how did the pest makers write these questions? What are the breadcrumbs we're supposed to be looking for?
Well, the ABIM writers have a very specific formula. If you learn to read the matrix of the question stem, the diagnosis practically jumps off the screen before you even reach the answer choices.
Okay, lay it on me.
Picture this scenario. You're on rounds or in clinic, and you have a 70-year-old man presenting. He's complaining of worsening, dull lower back pain and a generalized profound fatigue that's been creeping up on him over the last 4 or 5 months. You do what any good clinician would do. You order a routine set of labs. The complete blood count, the CBC, shows a mild normocytic anemia. Nothing shocking. His chemistry panel is relatively normal. But as your eyes scan down the lab report, you notice an unexpectedly elevated total serum protein level.
Okay, stop right there. I want to dissect this because if I'm moving too fast on a busy clinic day, or if I'm rushing through question block 3 on exam day, I'm going to read right past the most critical clues.
You definitely will if you're not careful.
First, let's talk about the age factor. The stem gave us a 70-year-old man.
Yeah, that is never filler text. In board world, age is a diagnostic parameter. The prevalence of MGUS, that foundational plasma cell disorder, increases linearly with age.
Right, it's a disease of older folks.
Exactly. In the general population, we're looking at roughly a 3% prevalence in people over the age of 50. But once you cross the threshold into the 70s and 80s, that prevalence jumps to 5% or even higher.
Yeah.
So just based on his demographic, a plasma cell issue should immediately load into your differential diagnosis.
And then there's the presentation itself. Back pain and fatigue. I mean, look at my waiting room on a Tuesday morning. Every single 70-year-old in there has back pain and fatigue. It is incredibly non-specific.
Which is exactly why the boards use it. They want to see if you can distinguish between, say, degenerative osteoarthritis and malignant bone destruction.
But the real trap, the thing that cracks the case wide open, is the incidental lab finding. This is how so many of these dyscrasias are discovered, right?
And almost all of the early ones, yeah.
You order a comprehensive metabolic panel, a CMP, maybe just to check their fasting glucose or their kidney function, and you see this elevated total serum protein. But wait, I want to pause here because this is where my brain always used to get stuck.
Okay, what's the hang-up?
When I look at a CMP, I see total protein, and right underneath it, I see albumin. Often on these board questions, the total protein is sky high, say it's 9.5 grams per deciliter. But the albumin is sitting there, completely normal, at 4.0. Where are the other 5.5 grams coming from? Is the machine just miscalibrated?
That discrepancy is arguably the most important concept in this entire field. It's the protein gap. If you understand the gap, you understand the disease.
Unpack the chemistry of that for me, because albumin is the heavy hitter in the blood, right? It maintains oncotic pressure, it carries hormones around.
It is. So the total protein in your blood is essentially the sum of two major categories, albumin and globulins.
Okay.
The liver manufactures albumin, and it usually makes up the lion's share of your total protein. The globulins are a diverse group of proteins that include your alpha, beta, and gamma globulins. The gamma globulins are your immunoglobulins, your antibodies.
Okay, so if my total protein is 9.5 and my albumin is 4.0, that means I have 5.5 grams of globulins circulating in my bloodstream.
Precisely. And a normal globulin level should only be around 2 to 3 grams per deciliter. So you have a massive unexplained surplus of globulins. Your body is overproducing antibodies at an industrial scale. The protein gap is basically the mathematical footprint of a rogue clone of plasma cells pumping out a massive amount of identical antibodies. The test writers use that gap to whisper in your ear, "Look at the bone marrow."
Ah, so there's an invisible factory churning out sludge, and the only way we noticed was because the total weight of the blood proteins tipped the scales.
Exactly.
That is a brilliant way to conceptualize it. So we see the gap, we suspect the invisible factory, but how do we actually prove it? We can't just jump straight to drilling into their hip bone for a marrow biopsy based on a routine blood draw.
No, you definitely don't want to do that.
Yeah.
There's a strict logical hierarchy to the diagnostic testing, and it starts with what we can measure in the serum and the urine.
I always call this the alphabet soup of testing. We throw around acronyms SPEP, UPEP, IEFLC. It can feel like a blur of letters if you don't anchor it to what the cells are physically doing.
It really can.
Let's ground this in the biology. What is a plasma cell, fundamentally?
So a plasma cell is a terminally differentiated B lymphocyte. It's the final, ultimate form of a B cell.
Right.
Its entire biological purpose is to act as a factory that manufactures and secretes immunoglobulins antibodies to fight off infections. In a healthy human body, you have a beautiful polyclonal response. You have thousands upon thousands of different plasma cell factories, and each factory is producing a slightly different type of antibody to target a slightly different threat.
But in a plasma cell dyscrasia, that diversity is destroyed. One single cell, one factory, acquires a genetic mutation, it goes rogue.
Yep, just takes one.
It starts cloning itself, multiplying out of control. And because every single new cell is an exact genetic replica of that original rogue cell, they all manufacture the exact same immunoglobulin. Billions of cells making one single identical protein. We call this the monoclonal protein, the M protein.
And here's where we need to address a massive terminology trap that catches trainees and test takers every single year. I want to clarify the difference between an M spike and IgM.
Oh, yes, please.
They sound similar, but confusing them on a board exam will lead you straight into a distractor answer.
Yes, this is so confusing at first glance. If I see M spike on a lab report, my brain automatically translates that to immunoglobulin M. Are you saying that's wrong?
It is entirely wrong. The M in M spike simply stands for monoclonal. It refers to the visual appearance of the protein on an electrophoresis gel. It makes a sharp spike.
Okay.
That monoclonal spike can be made of any class of immunoglobulin. It could be an IgGM spike. It could be an IgAM spike. It could even be an IgDM spike, though that's pretty rare.
Or it could just be the light chains, right?
Exactly. IgM, on the other hand, is a specific structural class of antibody immunoglobulin M. Now, it is possible to have an M spike that happens to be made of IgM, which is what drives Waldenström macroglobulinemia. But the letter M in M spike does not mean IgM. It just means a single clone is making it.
That distinction is crucial. Okay, so how do we actually visualize this spike? We order an SPEP and a UPEC serum and urine protein electrophoresis. I've always imagined this test like a microscopic racetrack for proteins. Can you walk through how that gel actually separates them out?
The racetrack analogy is perfect. In a laboratory, they take the patient's serum, place it on a special agarose gel, and apply a strong electrical current across it. One side is positive, one side is negative.
Okay, setting the track.
Proteins have varying sizes and varying electrical charges, so when you apply that current, they migrate across the gel at different speeds.
Like runners hearing the starting gun.
Right. Albumin is a relatively small molecule, and it carries a strong negative charge, so it absolutely zips across the gel toward the positive anode. It crosses the finish line first and forms a massive, dense band.
Makes sense.
Behind albumin, you get the alpha-1 and alpha-2 globulins, and then the beta-globulins. Finally, bringing up the rear, you have the gamma region. This is where the immunoglobulins migrate.
And what does that gamma region look like in someone who doesn't have a disease?
Well, in a healthy person, you have all those polyclonal antibodies. IgG, IgA, IgM, all slightly different shapes, sizes, and charges.
Yeah.
Because they're all slightly different, they all run the race at slightly different speeds.
That's right, they spread out.
Exactly. So when you plot their final positions on a graph, the gamma region looks like a wide, smooth, gently rolling hill. It's a broad smear on the gel.
Ah, but if you have a plasma cell dyscrasia, if you have billions of identical factories making billions of identical antibodies, they have the exact same molecular weight and the exact same electrical charge.
Exactly. They all run the race at the exact same speed, and they all pile up at the exact same physical location on the gel.
Wow.
On the graph, instead of a smooth rolling hill, you see a massive, sharp, narrow peak. It looks like a church spire jutting out of the baseline. That is your M spike.
Okay, that makes perfect sense visually. The SPEP proves there's a clone. It shows us the spike. But the septus just tells me a spike exists. It doesn't tell me what the spike is made of. I don't know if it's IgG or IgA. How do we figure that out?
That requires the next test in the sequence immunofixation, or IFE. If the SPEP is the radar that detects the plane, the immunofixation is the radio contact that asks for its flight number.
I like that.
IFE uses specific antibodies directed against the heavy and light chains to definitively type the protein. It'll tell you, this sharp spike you saw on the SAP is specifically an IgG molecule bound to a kappa light chain.
So we have the SPEP, the UPEP, the immunofixation, but there is one more vital piece of the diagnostic puzzle, right? The serum-free light chain assay, the FLC. I find that a lot of people struggle to understand why we need a separate test just for the light chains. Why isn't the whole antibody enough?
To understand the FLC assay, you have to visualize the physical structure of an antibody. Think of a standard IgG molecule. It looks like the capital letter Y.
Okay, I'm picturing it.
The long main trunk and the inner parts of the upper branches are called the heavy chains. Attached to the very outer tips of those upper branches are the light chains. And light chains come in two biological flavors, kappa and lambda.
So to build a functional, complete antibody, the plasma cell needs to manufacture both heavy chains and light chains and assemble them together.
Right. But here's the biological quirk. Plasma cells are notoriously inefficient factories. Their assembly lines are not perfectly synchronized. They almost always manufacture slightly more light chains than heavy chains.
Oh, right.
Yeah, so after they assemble all the full Y-shaped antibodies, there are leftover light chains just floating around inside the cell. The cell secretes them into the blood.
Hence the name free light chains. They aren't attached to a heavy chain trunk.
Exactly. Now, in a healthy person, your bone marrow naturally produces slightly more kappa light chains than lambda light chains. If we measure the ratio of kappa to lambda floating in your serum, the normal ratio sits comfortably between 0.26 and 1.65.
I want to push on this because this ratio concept is heavily tested. Let's say a patient has a massive systemic infection or severe rheumatoid arthritis. Their immune system is highly active, producing tons of antibodies, or maybe they have chronic kidney disease and their kidneys just aren't filtering proteins out of the blood very well. Won't their light chains be elevated? How do we know it's not cancer?
That's the crucial physiological distinction. In a state of generalized inflammation or in renal failure, the absolute numbers of both kappa and lambda will rise. They'll both be elevated outside the normal range. But, and this is the key, they rise proportionately.
I see.
The normal marrow is just revving its engine, so it makes more of everything. Because they rise together, the kappa to lambda ratio remains normal.
I see. The fraction doesn't change, even if the numerators and denominators are huge. But what happens when there is a malignant clone?
Well, if you have a rogue clone of plasma cells, and that specific clone is genetically programmed to only manufacture lambda light chains, It's going to pump mass amounts of lambda into the blood. The lambda numbers will shoot through the roof. Right.
Meanwhile, the kappa numbers will stay normal, or they might even drop because the massive tumor burden is physically suppressing the rest of the healthy bone marrow.
So the denominator explodes while the numerator shrinks.
Exactly. The ratio becomes severely skewed. You might see a ratio of 0.01 or a ratio of 400. An abnormal serum-free light chain ratio is a screaming siren for a clonal plasma cell disorder. It proves that the production is asymmetrical.
That is a phenomenal breakdown. So we've ordered the labs, we've identified the protein gap, we ran the SPEP, found the M spike, typed it with immunofixation, and confirmed an abnormal free light chain ratio. We have proven beyond a shadow of a doubt that a rogue clone exists in the patient's bone marrow. What now? This brings us to the core clinical challenge, the spectrum of disease. Because finding the clone is really just step one. Now we have to figure out how dangerous it is.
The word spectrum is vital here because this disease process is a true biological continuum. It's not an on-off switch. I always visualize this as a traffic light. It helps categorize the kinetics of the disease. Let's start with the green light. The car is sitting in the driveway with the engine idling. This is MGUS monoclonal gammopathy of undetermined significance. To be parked in the driveway, a patient must meet 3 very strict, mathematically precise criteria. And the boards will definitely test you on these numbers.
They absolutely will. First, the size of the M protein must be small, specifically less than 3 grams per deciliter on the SPEP.
Less than 3, got it.
Second, if you do a bone marrow biopsy, you must find less than 10% clonal plasma cells taking up space in the marrow. And third, and absolutely most importantly, there must be 0 evidence of end organ damage.
None at all.
The patient feels completely fine. Their bones are intact, their kidneys are filtering normally, their calcium is normal.
So we have a patient who meets these criteria. They have a pre-malignant clone. As a physician, my instinct is to eradicate it before it becomes a problem. But the guidelines say it's a green light to just observe. Why do we just watch? It feels wild to tell a patient, you have a precursor to a blood cancer, but I'll see you in 6 months.
It feels wild, but it's evidence-based medicine at its finest. If you treat MGUS with the heavy-hitting chemotherapy agents we use for active myeloma, you expose the patient to massive, life-altering toxicities, neuropathy, secondary leukemias, life-threatening blood clots, profound immunosuppression.
Wow. Okay.
And studies definitively show that treating MGUS does not improve overall survival. The cure is literally worse than the disease, especially considering that the average rate of progression from MGUS to active myeloma is only about 1% per year.
But 1% per year is an average. Some patients are going to progress faster, right? How do we know who is just going to sit in the driveway forever and who is about to put the car in gear?
We use risk stratification. We need to look under the hood. The ABIM frequently tests the Mayo Clinic risk stratification model for MGUS.
Okay, what are the factors?
There are 3 primary risk factors that predict progression. First, the size of that M protein. If it's greater than or equal to 1.5 grams per deciliter, they're at higher risk. Second, the type of the protein. Most MGUS is IgG. If the clone is producing a non-IgG protein like IgA or IgM, that's an independent risk factor for progression.
Oh, interesting. And the third?
And third, an abnormal serum-free light chain ratio.
So we add those up. If they have all 3 risk factors, what's their trajectory?
If they have all 3, their risk of progressing to full-blown myeloma over 20 years is nearly 60%. But if they have 0 risk factors, say an IgG spike of 0.5 and a normal light chain ratio, their 20-year risk of progression is only 5%.
That's a huge difference.
It really is. That low-risk patient will likely die of old age or cardiovascular disease long before their plasma cells ever cause a problem.
Okay, so that is the green light. Observation, with the intensity of our surveillance dictated by their Mayo risk score. Now let's look at the yellow light. The car is pulling out of the driveway and onto the street. We are proceeding with extreme caution. This is smoldering multiple myeloma. What changes here?
In smoldering myeloma, the biological burden of the disease has grown, but the patient remains asymptomatic. The numbers have crossed the threshold. The M protein is now greater than or equal to 3 grams per deciliter. Or the bone marrow biopsy shows between 10 and 59% clonal plasma cells.
But again, the absolute defining feature here is the lack of organ damage. They still have no bone lesions, no kidney failure.
Correct. But the kinetic energy of the disease has shifted. Remember how MGUS progresses at roughly 1% per year?
Yeah.
Smoldering myeloma progresses at a rate of 10% per year for the first 5 years after diagnosis. The engine is revving high. These patients need rigorous, close clinical monitoring, often every few months, because they're basically on the precipice.
Which leads us to the red light. The car is speeding down the highway, weaving through traffic, and we have to slam on the brakes immediately. This is active multiple myeloma. It is time to treat. And to know when to initiate treatment, you have to know what defines active myeloma.
Absolutely.
The boards expect every single internal medicine physician to have the CRAB criteria memorized cold. CRAB. Let's break down these parameters of end organ damage because the pathophysiology here is fascinating. Let's start with C.
C is for hypercalcemia. And to understand the hypercalcemia, we actually have to talk about the B and CRAB simultaneously, which is bone disease. The two are inextricably linked.
This is a point of confusion for a lot of people. If I have a tumor growing in my bone marrow, my assumption is that the physical mass of the tumor is just pushing against the bone and breaking it like a tree root cracking a sidewalk. But that's not what's happening, is it?
Not at all. The plasma cells are far more insidious than that. They act like malicious architects. They don't tear down the bone themselves. Instead, they secrete a barrage of chemical signals, cytokines like MIP-1 alpha and DKK-1, that fundamentally hijack the normal bone remodeling process.
In a healthy bone, you have a delicate balance between osteoclasts, which are the cells that chew up and resorb old bone, and osteoblasts, which are the cells that lay down new, fresh bone.
Exactly. The myeloma cells secrete cytokines that massively upregulate ORANC ligand, which hyperactivates the osteoclasts. They hand sledgehammers to the osteoclasts and tell them to go to work.
Just nonstop destruction.
Yeah, and simultaneously, they secrete inhibitors that completely paralyze the osteoblasts.
It is a double hit. You have runaway, uncoupled bone destruction with zero biological repair.
And that leads to the classic lytic bone lesions we see on imaging. They look like punched-out holes in the skull, the spine, the pelvis. It severely weakens the structural integrity of the skeleton, leading to catastrophic pathologic fractures. A patient might break their femur just from standing up out of a chair.
Terrifying.
And because all that dense bone matrix is being dissolved so rapidly, massive amounts of stored calcium are dumped directly into the bloodstream.
Thus, the hypercalcemia. And as a quick clinical correlation for the boards, because the osteoblasts, the bone-building cells, are paralyzed, the serum alkaline phosphatase level in a myeloma patient is usually completely normal.
Yes, great point.
Alkaline phosphatase is a marker of osteoblast activity. If you see lytic bone lesions with a normal OCPHOS, myeloma should be at the very top of your list.
Okay, so that covers C for calcium and B for bone disease. Let's hit the R, renal failure.
This is arguably the most highly tested mechanism in the entire subject. The most common cause of acute kidney injury in multiple myeloma is a condition called cast nephropathy, colloquially known as myeloma kidney. And to understand this, we have to follow the free light chains.
Right, those extra branches the factories are pumping out. Because free light chains are low molecular weight proteins, only about 25 kilodaltons, they easily bypass the filtration barrier of the glomerulus. They pass freely from the blood into the proximal tubule of the nephron.
Okay.
Normally, the proximal tubule has receptors, megalin and cubolin, that grab these light chains, reabsorb them, and break them down.
But in myeloma, there are millions of light chains. The proximal tubule is completely overwhelmed. The assembly line gets backed up.
Exactly. The reabsorption capacity is maxed out, so the excess light chains continue flowing downstream through the loop of Henle until they reach the distal convoluted tubule. Now, the cells of the thick ascending limb and the distal tubule secrete a normal physiologic protein called Tam-Horsfall protein, or urinomodulin. It's meant to protect the urinary tract from infections and kidney stones.
But when you introduce massive quantities of monoclonal free light chains into that environment,
They bind together. The light chains and the Tam-Horsfall protein interlock. And under the right conditions, specifically if the tubule is acidic, or if the flow of urine is sluggish because the patient is dehydrated or hypercalcemic, they precipitate.
oh, wow.
They form solid, dense, waxy casts that physically plug up the distal tubule.
It is a microscopic mechanical obstruction. It's like pouring wet cement down a sink drain. The plumbing backs up, the pressure inside the nephron spikes, the glomerulus stops filtering, and the patient goes into acute renal failure. It is a brilliant, terrifying mechanism. We'll talk later about the specific board traps related to making this worse. All right, the last letter in the CRAB acronym is A for anemia.
The anemia is typically normocytic and normochromic. The mechanism here is relatively straightforward compared to the kidneys and bones. It's primarily a space issue.
Just crowding them out.
basically. As the rogue plasma cells aggressively clone themselves, they physically pack the bone marrow space. They crowd out the normal hematopoietic stem cells. There's simply no physical room left for erythropoiesis, the production of red blood cells. The factories are shut down due to lack of real estate.
So, to synthesize, if you have a proven clone and the patient has any of the CRAB criteria, hypercalcemia, renal failure, anemia, or bone lesions, they have active multiple myeloma, and you must initiate treatment immediately. But here's where the paradigm has shifted in recent years, and the boards expect you to know the updated guidelines. We no longer wait for the patient's spine to fracture or their kidneys to fail before we pull the trigger. We have the SLIM criteria.
The SLIM criteria represent a massive leap forward. We realized that waiting for overt end organ damage was doing a disservice to a subset of extremely high-risk patients. The SLIM criteria are myeloma-defining biomarkers. If a patient meets even one of these criteria, epidemiological data shows their risk of progressing to catastrophic C-CRAB features within 2 years is over 80%. So we reclassified them. We now consider them to have active myeloma, even if they're completely asymptomatic, and we treat them to prevent the organ damage from ever occurring.
SLIM is another acronym. Let's walk through it. S stands for 60. If the bone marrow biopsy shows greater than or equal to 60% clonal plasma cells, you treat. Period. The marrow is simply too packed.
Right. LI stands for light chains. Specifically, we look at the involved to uninvolved free light chain ratio. If that ratio is greater than or equal to 100, meaning the malignant light chain outnumbers the normal light chain by 100 to 1, you treat. That clone is too biologically aggressive to ignore.
And M stands for MRI. If a whole body MRI shows one or more focal bone lesions measuring at least 5 millimeters in size, even if the plain X-rays are totally clear and the patient has no pain, you treat. You caught the architectural damage before it compromised the structural integrity of the bone. So, the summary algorithm. CRAB criteria mean the damage is already done. SLIM criteria mean the damage is mathematically imminent. Either way, the light is red and you initiate therapy. Which perfectly transitions us to the management side of the equation. The boards do not expect an internal medicine physician to be a practicing hematologist-oncologist. They won't ask you to design a complex, multi-drug salvage regimen, but they absolutely expect you to know the broad architectural strokes of treatment, and far more importantly, the specific toxicities of the frontline drugs, because those toxicities end up in the primary care clinic and the emergency department.
The very first branch point in the management algorithm, once you have diagnosed active myeloma, is determining if the patient is eligible for an autologous hematopoietic stem cell transplant, or HSCT.
Let's clarify the terminology here, because transplant can evoke the wrong image. It is an autologous transplant, auto meaning self. We are not giving them someone else's immune system like we do in leukemia.
Right. An allogeneic transplant from a donor is rarely used in myeloma due to incredibly high mortality rates. In an autologous transplant, we harvest the patient's own healthy peripheral blood stem cells. We literally filter them out of their blood and put them in a freezer.
Okay.
Then we hit the patient with massive myeloablative doses of chemotherapy, usually a drug called melphalan. The goal is to completely nuke the bone marrow, killing every single microscopic plasma cell we can possibly reach.
But if we just stopped there, the patient would have no immune system and no ability to make red blood cells or platelets. They would die of a basic infection or a minor bleed within weeks.
Exactly. So we go to the freezer, thaw out their own healthy stem cells, and infuse them back into the bloodstream. Those stem cells home back to the empty bone marrow space, engraft, and rescue the patient's blood counts.
That's amazing.
It is, but it's a brutal, physically exhausting process. That's why transplant eligibility is strictly based on chronological age, functional status, and cardiopulmonary comorbidities.
And here is a vital point for board exams and patient counseling. Autologous HSCT is not curative. Let me repeat that. It is not a cure for multiple myeloma. The disease will almost certainly relapse at some point. However, it significantly deepens the remission, and it drastically improves both progression-free survival and overall survival. It buys them years of quality life.
But whether a patient is eligible for a transplant or not, their journey will involve myeloma-directed chemotherapy. Modern regimens usually consist of a triplet or quadruplet therapy: a proteasome inhibitor, an immunomodulatory drug, a steroid, and often a monoclonal antibody. And you must know the adverse effects. Let's start with the immunomodulatory drugs, specifically lenalidomide.
Lenalidomide is the oral backbone of myeloma therapy. It's a derivative of thalidomide, but it carries a massive, highly testable toxicity. It drastically alters the coagulation cascade, significantly increasing the risk of venous thromboembolism, deep vein thrombosis, pulmonary embolisms. The boards will present a vignette of a patient who has just started on lenalidomide and dexamethasone, and they'll ask you for the most appropriate next step in preventative management.
And the answer is always, unequivocally, DDT prophylaxis. You cannot send a patient home on lenalidomide without addressing the clotting risk. Depending on their individual risk factors, they absolutely must be placed on low-dose daily aspirin at a bare minimum, or full systemic anticoagulation if they have a history of clots. If you see lenalidomide in the question stem, actively look for the aspirin in the answer choices.
Then we have bortezomib. This is a proteasome inhibitor. It works by blocking the cellular garbage disposal. Plasma cells produce massive amounts of protein, and they rely on proteasomes to degrade the misfolded ones. Bortezomib blocks that degradation, so the garbage proteins build up until the cell literally chokes on its own waste and undergoes apoptosis. But it doesn't just affect plasma cells, it affects neurons.
The major dose-limiting toxicity for bortezomib is peripheral neuropathy. It can be incredibly painful, burning, and debilitating, often starting in the toes and fingers. If a patient develops severe neuropathy, you have to dose reduce or switch agents.
Finally, we need to talk about daratumumab. This drug revolutionized myeloma care. It's a monoclonal antibody targeted specifically against CD38, a cell surface receptor that's highly expressed on malignant plasma cells. But CD38 is also present on the surface of normal red blood cells.
And this creates an absolute nightmare for the hospital blood bank.
Oh, totally.
Because daratumumab is circulating in the blood, it binds to the CD38 on the patient's healthy red blood cells. Now imagine this patient needs a blood transfusion, which is common in myeloma. The lab runs an indirect Coombs test or an antibody screen to make sure the patient doesn't have low antibodies against the donor blood.
But the screening red cells also have CD38 on them, so the daratumumab binds to the screening cells, the region antibodies bind to the daratumumab, and the test comes back blaringly, overwhelmingly positive across all cell panels.
It exhibits pan-reactivity. To the automated machines, it looks exactly like a catastrophic warm autoimmune hemolytic anemia. It completely masks any real underlying low antibodies the patient might actually have.
What a mess.
It really makes safely cross-matching donor blood incredibly difficult and time-consuming. The boards love testing this piece of logistical trivia. You have to notify the blood bank before starting a patient on daratumumab so they can phenotype the patient's blood baseline.
It's the perfect example of how an elegant biological treatment for one condition completely sabotages the diagnostic infrastructure for another. All right, before we test this knowledge with clinical vignettes, we have to look sideways at the two major cousins of multiple myeloma, AL amyloidosis and Waldenström macroglobulinemia. These are plasma cell dyscrasias that cause devastation not by drilling holes in the bone, but strictly through the physical properties of the toxic proteins they secrete.
Let's delve into AL amyloidosis first. The A stands for amyloid and the L stands for light chain. In this disease, you have a rogue plasma cell clone, just like we discussed earlier. It's secreting free light chains into the serum. But these specific light chains possess a unique, tragic genetic mutation that causes them to be thermodynamically unstable. They misfold.
The three-dimensional structure of the protein collapses. Instead of staying neatly dissolved in the blood plasma, these misfolded light chains start snapping together. I visualize them like tiny molecular Lego bricks. They stack on top of each other, forming rigid, insoluble fibrils called beta-pleated sheets. This is the amyloid protein. And because it's insoluble, it drops out of the blood and starts depositing in the extracellular space of tissues all over the body.
And wherever that amyloid deposits, it causes profound architectural damage. It causes the organ to thicken, to stiffen, and eventually to fail mechanically. If the amyloid fibrils deposit in the glomeruli of the kidneys, they disrupt the delicate filtration barrier, leading to a massive, unchecked protein leak.
Nephrotic syndrome.
Exactly. These patients present with classic nephrotic syndrome, profound peripheral edema, anasarca, and foamy urine with massive albuminuria.
If it deposits in the myocardial tissue of the heart, the ventricular walls become incredibly thick, beefy, and rigid. The heart can't relax to fill with blood during diastole. This leads to a restrictive cardiomyopathy, specifically presenting as heart failure with preserved ejection fraction, or HFpEF.
The soft tissue and vascular findings are incredibly high yield for exams because they're so visually distinct. If the amyloid deposits in the muscular tissue of the tongue, it causes macroglosia, a massively enlarged, stiff tongue that often has scalloped indentations along the edges from pressing against the teeth.
And if it deposits in the walls of the capillaries and small blood vessels, the vessels become rigid and extremely fragile. Even minor changes in venous pressure or slight physical trauma causes them to shatter and bleed into the skin. This leads to the classic raccoon eyes, periorbital purpura, that appears after the patient simply coughs vigorously, vomits, or rubs their eyes. You can also see pinch purpura, where gently pinching the skin on their arm leaves a dark bruise.
To definitively diagnose AL amyloidosis, you cannot rely on blood tests alone. You need to secure a tissue biopsy to visually prove the amyloid deposits exist. You can biopsy the affected organ directly, like a kidney or a cardiac biopsy, but those are invasive and risky. Often we perform an abdominal fat pad aspirate, which is a simple bedside procedure.
And the pathology lab technique here is legendary in medical education.
It is. When the pathologist stains that biopsy tissue with a specific dye called Congo red and then examines it under a microscope equipped with a polarized light filter, the amyloid fibrils reflect the light in a very specific way. They glow with a brilliant, luminous green color.
Apple green birefringence.
That's the one. This is the classic apple green birefringence. If a board question mentions a Congo red stain or apple green birefringence, you stop reading, you lock in the diagnosis of amyloidosis, and you move to the next question.
Okay, that is AL amyloid. What about Waldenström macroglobulinemia? The name alone is a mouthful.
Waldenström is a different beast entirely. It's not a pure plasma cell disorder. It's technically classified as a lymphoplasmacytic lymphoma. The malignant clone is biologically stuck somewhere in the middle of differentiating from a mature B cell into a plasma cell. And this specific clone almost exclusively produces immunoglobulin M.
And the specific physical structure of IgM is the absolute key to understanding why patients develop the symptoms they do. Remember our antibody structures. IgG and IgA are relatively small molecules. They're monomers or dimers. But IgM is a massive, bulky pentamer. It consists of 5 Y-shaped antibody units linked together in a circle by a J chain. It looks like a giant molecular snowflake. It's physically huge with a very high molecular weight.
And because it's so large, the vast majority of it cannot leak out of the blood vessels into the interstitial space. It remains trapped inside the intravascular compartment. So when this malignant clone starts pumping out massive, unregulated quantities of this huge IgM pentamer, the physical properties of the blood change.
The hyperviscosity.
Yes. The serum literally becomes thick and viscous. It goes from flowing like water to flowing like maple syrup. This is the pathophysiology of hyperviscosity syndrome.
Imagine the sheer mechanical strain on the cardiovascular system. The heart is trying to pump maple syrup through microscopic capillaries. The thick, viscous blood begins to sludge and stagnate in the microvasculature. In the central nervous system, this sludging leads to poor oxygen delivery, causing severe headaches, dizziness, vertigo, and eventually altered mental status or coma.
In the eyes, the sluggish flow causes the delicate retinal veins to engorge and back up. On a fundoscopic exam, the veins look dilated, tortuous, and segmented, often described as looking like sausages. The increased pressure causes retinal hemorrhages, leading to sudden blurry vision or even permanent vision loss.
And paradoxically, even though the blood is thick, these patients often present with severe mucosal bleeding, like massive, uncontrollable nosebleeds or bleeding gums.
That happens because the massive IgM pentamers physically coat the surface of the platelets and the endothelial lining, interfering with platelet adhesion and aggregation. The platelets are there, but they're too slippery to form a proper clot. Furthermore, the IgM can bind to von Willebrand factor and clear it from the circulation, causing an acquired von Willebrand syndrome.
It's a hematological disaster, and the treatment for symptomatic Waldenström hyperviscosity is a true medical emergency. You cannot wait for chemotherapy to slowly kill the clone. You have to physically remove that thick IgM from the patient's blood immediately to save their vision and protect their brain. We'll dive into the specific mechanics of that in just a moment.
It's intense.
Wow, we've covered a staggering amount of deep pathophysiology, but understanding the why makes memorizing the what so much easier. Let's take all of these raw foundational concepts and see exactly how the exam raters deploy them to trick you. It's time to walk through some board-style clinical vignettes.
We're going to treat these vignettes as interactive clinical reasoning exercises. As I read this stem, I want you listening to actively pick out the hidden breadcrumbs. Try to build the diagnosis in your head before you even finish the paragraph. Then we'll break down the diagnosis, identify the correct next step in management, and crucially, we'll explain exactly why the distractor answers are wrong. Because understanding the traps is how you master the exam.
Let's do it. Vignette number 1. The incidental finding.
Here's a scenario. A 65-year-old woman presents to your clinic for a routine annual wellness exam. She reports feeling well and specifically denies any bone pain, fatigue, night sweats, or unintentional weight loss. Her physical exam is completely unremarkable. You order routine screening labs. Her CBC is normal, with a hemoglobin of 13.5. Her serum calcium is 9.2, which is normal, and her serum creatinine is 0.9, also normal. However, her comprehensive metabolic panel reveals an elevated total serum protein of 8.2 grams per deciliter, with a normal albumin of 4.1. You correctly order a serum protein electrophoresis and SBEP, which reveals a 1.2 gram per deciliter IgG-M spike. A subsequent bone marrow biopsy demonstrates 5% clonal plasma cells. What is the most appropriate next step in the management of this patient?
Okay, let's unpack this systematically. We have the classic setup, an older patient, totally asymptomatic. The routine labs flagged a protein, gap total protein of 8.2 minus albumin of 4.1 leaves a gap of 4.1, which is elevated. That prompted the SBEP, which confirmed a monoclonal clone. Now, we have to run her numbers through our traffic light criteria to see where she sits on the spectrum.
Her M spike is 1.2 grams per deciliter. That's less than the 3.0 threshold. Her bone marrow biopsy shows 5% clonal cells. That's less than the 10% threshold. And most importantly, look at her clinical picture. Normal hemoglobin, normal calcium, normal creatinine, no bone pain. She has 0 CR criteria.
So she's sitting squarely in the driveway at the green light. The diagnosis is definitive.
Oh, yeah.
Monoclonal gammopathy of undetermined significance, MGUS.
So what's the next best step? Since she has MGUS, we know we do not initiate active treatment. The correct overarching answer is observation and surveillance. You'll monitor her labs every 6 to 12 months. However, there's one highly testable addition to her immediate management. You should order a baseline bone mineral density scan, a DXA scan.
Wait, really? She has no bone pain and her calcium is normal. We know MGUS doesn't cause those punched out lytic lesions. Why are we scanning her bones?
Because the subtle low-level cytokine changes induced by that small clone, while not enough to cause overt lytic holes, can still tilt the balance of bone remodeling toward osteoclast activity. MGUS patients are at a statistically significant increased risk for age-inappropriate bone loss, osteopenia, and osteoporosis, independent of the progression to myeloma. You need a baseline DXA to evaluate her overall bone health.
That makes perfect sense. Now let's look at the classic distractors the boards will offer you. Distractor A, initiate lenalidomide and dexamethasone. Why is this wrong?
Because she has 0 end organ damage. Initiating aggressive chemotherapy in an asymptomatic MGUS patient provides absolutely no survival benefit and only exposes her to severe toxicities, like the DVT risk from lenalidomide. You never treat MGUS.
Distractor B, order a whole-body PT-CT scan to evaluate for occult olytic lesions. This is such a tempting answer. She has a plasma cell clone. Why not scan her entire skeleton just to be absolutely safe? Why is that wrong?
It's tempting because we're trained to be thorough. But remember the Mayo Clinic risk stratification we discussed. This patient has low-risk features. Her M spike is IgG and less than 1.5. If her free light chain ratio is normal and she has no symptoms, the statistical probability of finding an occult lesion is virtually 0. Advanced skeletal imaging like a PET-CT or a whole-body MRI in this specific low-risk phenotype is unnecessary, expensive, and low yield. It's an over-testing trap. You reserve those advanced scans for patients with high-risk MGUS or suspected smoldering myeloma.
Brilliant. Proceed with caution, don't overtest. Moving to vignette number 2, the kidney trap. I love this one because it plays out on the internal medicine wards every single day.
The stem. A 70-year-old man with a known, established history of multiple myeloma presents to the emergency department with severe nausea, lethargy, and decreased urine output over the last 24 hours. His baseline creatinine from last month was 1.1. Today, his serum creatinine is 4.5.
Huh.
You review his recent medical chart and note 2 critical pieces of history. He underwent a CT scan of the abdomen with intravenous iodinated contrast 2 days ago for vague abdominal pain. And he reports taking high, around-the-clock doses of over-the-counter ibuprofen for worsening lower back pain. A urinalysis is performed in the ED. It shows a bland sediment with no red blood cells or white blood cell casts, but it is strongly positive for total protein. What is the most likely pathophysiological mechanism of his acute kidney injury, and what is the absolute most appropriate next step in management?
Well, let's synthesize the moving parts here. We have a patient with known active myeloma. He presents in acute renal failure. His creatinine has quadrupled. And the stem hands us 2 major recent insults to his kidneys: 4D contrast dye and high-dose NSAIDs.
The overarching diagnosis here is myeloma kidney, specifically cast nephropathy. But the question wants you to understand how his recent actions triggered it.
Let's trace the physiology. He has active myeloma, so his bone marrow is pumping out massive quantities of free light chains. They're being filtered by the glomerulus and traveling down into his renal tubules. But they were probably flowing okay last week. Then he took the ibuprofen. NSAIDs work by inhibiting prostaglandins. In the kidney, prostaglandins are responsible for keeping the afferent arteriole, the blood vessel feeding the glomerulus, dilated and open.
Exactly. When he took the NSAIDs, he removed that vasodilation. The afferent arteriole clamped down, the blood flow into the glomerulus plummeted, which means his glomerular filtration rate, his GFR, dropped significantly.
When GFR drops, the flow of fluid moving through the physical tubes of the nephrons slows down to a crawl. The river dries up.
Now add the second insult, the IV contrast dye. Radiocontrast is highly hyperosmolar. It causes direct tubular toxicity and further intense renal vasoconstriction. So now the flow in his tubules is incredibly sluggish and the environment is toxic.
And this creates the perfect storm for cast nephropathy. Those free light chains are sitting stagnant in the distal tubule alongside the TAM-Horsfall protein. Because the flow is so slow, they have plenty of time to interact, bind together, and precipitate into dense, solid casts. They physically concrete the tubules shut.
Notice the vital clue hidden in the urinalysis. A bland sediment, but strongly positive for total protein. This is the hallmark signature of cast nephropathy. The bland sediment means there's no active glomerulonephritis, no red cells, no white cells. The positive protein is entirely composed of those free light chains, not albumin.
Okay, so his kidneys are clogged with cement. What is the next best step? The correct answer is to stop the NSAIDs immediately and initiate aggressive intravenous hydration with normal saline.
The goal of therapy is purely mechanical. You have to flush the plumbing. By giving aggressive 5E fluids, you increase the intravascular volume, force open the afferent arteriole, increase the GFR, and speed up the flow of fluid through the tubules. High flow rates prevent the light chains and TAM-Horsfall proteins from having the time to bind together, and it can help wash out casts that are just beginning to form.
Let's destroy the distractors because there is a lethal trap here. Distractor A, administer intravenous furosemide to increase urine output.
This is a massive fatal board trap. The logic seems sound to a stressed test taker. The patient is oliguric, his kidneys aren't making urine. I should give a powerful loop diuretic to force the kidneys to pee.
But what does furosemide actually do in this specific microenvironment?
Loop diuretics act on the thick ascending limb of the loop of Henle. And studies have shown that loop diuretics actually promote the precipitation of TAM-Horsfall protein. They make it more sticky. Furthermore, giving a diuretic volume depletes the patient. It dehydrates them further. This drops the GFR even lower and slows the tubular flow to an absolute standstill. If you give a loop diuretic to a patient actively forming light chain casts, you will accelerate the cast formation and cement their kidney shut permanently. You never use diuretics in cast nephropathy unless the patient is in florid, life-threatening pulmonary edema from fluid overload.
Such a dangerous trap. What about distractor B? Start an ACE inhibitor to reduce the proteinuria.
Wrong mechanism entirely. ACE inhibitors are fantastic for managing the albuminuria seen in diabetic nephropathy because they dilate the efferent arteriole, reducing the hydrostatic pressure inside the glomerulus. But this patient doesn't have a glomerular pressure problem. He has a tubular obstruction problem. Lowering the glomerular pressure with an ACE inhibitor will just decrease his filtration rate further, slow down the tubular flow, and worsen the cast formation.
You have to know the physiology, not just pattern recognize the word proteinuria.
Okay, vignette number 3. The blurry vision emergency.
STEM. A 68-year-old man is brought to the urgent care clinic by his wife. He's complaining of profound fatigue, frequent and severe nosebleeds over the last week, and a new onset progressive blurring of his vision. On physical exam, he appears lethargic and confused. Palpation of his abdomen reveals moderate hepatosplenomegaly. You perform a fundoscopic exam and note significantly dilated, tortuous retinal veins with scattered retinal hemorrhages. Urgent laboratory workup reveals a massive M spike of 5.0 grams per deciliter. Immunofixation confirms that the spike is entirely composed of IgM. What is the single most appropriate next step in management?
The clinical picture here is loud and clear. Hepatosplenomegaly implies the malignant cells are infiltrating the tissues. The massive M spike, definitively typed as IgM, points directly to Waldenström macroglobulinemia.
And the symptom cluster, the lethargy, the severe epistaxis, and the blurry vision with those classic sausage-like engorged retinal veins, is the textbook presentation of hyperviscosity syndrome. His blood is sludging. The IgM pentamers have turned his serum into syrup. The sluggish flow is starving his brain of oxygen, blowing out the fragile veins in his retina, and coating his platelets so he can't stop a nosebleed.
The diagnosis is Waldenström macroglobulinemia, complicated by symptomatic hyperviscosity syndrome. The question asks for the most appropriate next step, and the correct answer is emergent therapeutic apheresis, specifically plasmapheresis.
Explain the mechanics of that.
Plasmapheresis is a mechanical intervention. You place a large bore catheter in the patient, hook them up to an apheresis machine, and continuously draw their blood out. The machine uses a centrifuge to separate the dense cellular components, the red and white blood cells, from the liquid plasma. We keep the patient's plasma, which contains all of that massive toxic IgM, and we throw it in the biohazard bin. We then mix the patient's red blood cells with donor plasma or an albumin solution and infuse it back into the patient. You're literally performing an oil change. You physically remove the sludge, immediately lowering the viscosity of the blood, restoring perfusion to the brain and the eyes.
It's an incredible, life-saving procedure. Now let's look at the distractor, because this is where the exam writers show no mercy. Distractor A, administer rituximab immediately to target the malignant B-cell clone.
This is devilishly tricky. Rituximab is an anti-CD20 monoclonal antibody, and Waldenström cells express CD20. Rituximab is, in fact, the standard of care frontline chemotherapy for Waldenström macroglobulinemia. It's the right drug for the disease.
But if it's the right drug, why is it the wrong answer?
Because it's the wrong timing. Giving rituximab as the first intervention in a patient who already has active symptomatic hyperviscosity is a fatal board trap. When you infuse rituximab, it binds to the malignant cells. Before those cells die, they often react by rapidly dumping their intracellular contents. This causes a transient massive spike in serum IgM levels, a phenomenon known as the IgM flare.
Oh, wow. So if his blood is already dangerously thick at the absolute upper limit of what the cardiovascular system can handle,
that sudden drug-induced spike in IgM will tip him over the edge. His blood viscosity will critically peak, leading to immediate catastrophic microvascular occlusion. You can induce a massive ischemic stroke, irreversible blindness, or a coma. You must perform plasmapheresis first to manually lower the IgM to a safe baseline. Only then, days later, is it safe to initiate the rituximab therapy.
that is unbelievably high yield. Do not fall for the rituximab trap in a hyperviscosity crisis. Let's move to vignette number 4, the heart failure mystery.
A 60-year-old man presents to the cardiology clinic with worsening shortness of breath on exertion and progressive bilateral lower extremity edema. His past medical history is notable for bilateral carpal tunnel syndrome, which required surgical release 2 years ago. On physical examination, you note elevated jugular venous pressure, crackles at the lung bases, and easily provoked dark bruising around both eyes. An echocardiogram demonstrates severe biatrial enlargement, profound concentric thickening of the left ventricle, and a preserved ejection fraction of 60%. However, an electrocardiogram, an ECG performed in the clinic, shows unexpectedly low voltage QRS complexes in the limb leads. A subsequent urinalysis reveals 3+ protein, which a 24-hour collection confirms is nephrotic range proteinuria. What is the most definitive next step to establish the diagnosis?
I absolutely love the juxtaposition of the clues in the stem. Let's look at the heart first. The echo shows a thick, beefy, hypertrophied left ventricle. Normally, when you see a thick heart muscle like in a patient with chronic, uncontrolled hypertension, the ECG reflects that massive muscle bulk. You expect to see huge, towering QRS complexes, the classic criteria for left ventricular hypertrophy.
Exactly, but this patient's ECG shows the exact opposite. It shows low voltage, tiny little blips on the paper.
Why the mismatch?
Because that massive thickening you see on the echocardiogram is an illusion. It isn't actually cardiac muscle. The actual myocytes, the cells that generate the electrical voltage, are being crushed and replaced by inert, electrically silent deposits of amyloid protein. The walls are thick with amyloid, not muscle, hence the low voltage on the ECG. This discordance, a thick wall on echo with low voltage on ECG, is the classic hallmark of cardiac amyloidosis.
And the rest of the stem perfectly supports that. He has a restrictive cardiomyopathy, HFpEF. He has bilateral carpal tunnel syndrome, which occurs because the amyloid fibrils precipitate in the tight space of the flexor retinaculum in the wrist, compressing the median nerve. He has the periorbital ecchymosis, the raccoon eyes, from amyloid infiltrating and weakening the capillary walls. And he has nephrotic syndrome from the amyloid destroying his glomeruli.
The clinical diagnosis is undoubtedly AL amyloidosis, but the question asks for the most definitive next step to establish the diagnosis. In medicine, definitive almost always means tissue pathology. The correct answer is to perform an abdominal fat pad aspiration biopsy and stain it with Congo red.
We need to see that apple green birefringence under polarized light to prove the amyloid exists.
Exactly. Let's look at distractor A cardiac MRI.
A cardiac MRI is an incredible imaging modality. It would show diffuse subendocardial late gadolinium enhancement, which is highly sensitive and specific for cardiac amyloidosis. Why is it wrong?
Because while a cardiac MRI is strongly suggestive, it is not considered the definitive gold standard diagnostic test. Imaging alone cannot definitively differentiate between AL amyloid, caused by a plasma cell clone, and ATTR amyloid, which is caused by a misfolded liver protein, transthyretin. You absolutely must have tissue to type the amyloid, because the treatments for AL and ATTR are completely different.
What about distractor B? Proceed directly to a bone marrow biopsy and initiate melphalan-based chemotherapy.
This is wrong because it skips a crucial step. Yes, AL amyloid is driven by a clonal plasma cell disorder in the marrow, and yes, you'll eventually need a bone marrow biopsy to assess the clone size. But you cannot simply look at a patient with heart failure and raccoon eyes, assume they have amyloidosis, and commit them to highly toxic myeloablative chemotherapy without pathological proof. You must prove the protein deposits exist in the tissue first.
Perfect clinical reasoning. Let's hit our final vignette number 5, the benign proteinuria.
Step. A 55-year-old man with absolutely no history of diabetes, mellitus, or hypertension is referred to a nephrologist for evaluation of progressive, severe lower extremity edema. Laboratory workup reveals a serum creatinine of 1.4 milligrams per deciliter, and a 24-hour urine collection quantifies 4.5 grams of protein, confirming nephrotic syndrome. A thorough workup for autoimmune and viral causes of nephropathy is entirely negative. An SPEP is performed. It reveals a small 0.8 gram per deciliter IgG spike. A bone marrow biopsy demonstrates 3% clonal plasma cells. A skeletal survey shows no oolitic bone lesions, and his serum calcium is normal. What is the most accurate diagnosis, and what is the next best step in management?
Okay, this is a tricky one. Let's run his numbers through the traffic light criteria. His M spike is only 0.8. That's well below the 3.0 threshold. His bone marrow only has 3% clonal cells, which is well below the 10% threshold. He has no hypercalcemia, no anemia, and no bone lesions.
Technically, by the strict numerical definition, he perfectly meets the criteria for MGUS, the green light.
But we can't ignore the elephant in the room. He has 4.5 grams of protein pouring into his urine every day. He has massive kidney-destroying nephrotic syndrome that is profound end organ damage. But it's entirely isolated to the kidney, and it doesn't fit the classic cast nephropathy pattern we see in overt multiple myeloma because his clone burden is so incredibly small.
This represents a relatively newer, highly tested conceptual category in hematology. The diagnosis is MGRS, monoclonal gammopathy of renal significance.
Explain the pathophysiology of MGRS. How can such a tiny clone cause so much damage?
In MGRS, the size of the clone is irrelevant. The issue is the specific physicochemical properties of the monoclonal protein it's secreting. Even though there are only a few malignant plasma cells, only 3% of the marrow, the specific light chains or heavy chains they happen to be manufacturing are exquisitely, uniquely toxic to the renal glomerulus. They might be depositing as amyloid fibrils, or causing monoclonal immunoglobulin deposition disease, or MIDD, or triggering a severe membranoproliferative glomerulonephritis pattern.
The clone is small, but it's secreting pure poison for the kidney. So what's the next best step?
You must perform a renal biopsy. You have to prove pathologically that the glomerular damage is directly being caused by the deposition of that specific monoclonal protein. And once that is confirmed, the management paradigm shifts completely. You must initiate aggressive, myeloma-like chemotherapy. You use the heavy-hitting drugs bortezomib, cyclophosphamide, daratumumab to completely eradicate that tiny clone and shut down the production of the toxic protein.
And the ultimate board trap here, the distractor answer, is to look at the numbers, the 0.8 M spike and the 3% marrow, label the patient as having just MGUS, and choose observation and routine follow-up as the management plan.
That's a critical error. If you choose observation, you are allowing that tiny clone to continuously secrete its toxic protein. The patient's glomeruli will be progressively destroyed, and they'll rapidly progress to irreversible end-stage renal disease and require lifelong dialysis. You cannot ignore severe end-organ damage simply because the clone size is mathematically small. MGRS requires aggressive clone-directed treatment to save the organ.
That's a phenomenal conceptual pivot and a perfect transition into our next focus. Let's pressure test this knowledge. We've covered a lot of ground, and I want to rapidly extract the absolute most important high-yield facts. I'm going to throw a scenario or a question at you, and I want you to hit me with the immediate reflex board answer.
I'm ready. Let's do it.
Okay, pressure test number 1. I suspect my patient has multiple myeloma. I need to look for olytic bone lesions. I order a standard radiographic skeletal survey, a series of plain x-rays of the whole body. Good or bad idea?
Bad idea. The boards want you to choose a whole-body PT-CT, or alternatively, a whole-body low-dose CT or a whole-body MRI as the best initial imaging test. For decades, plain x-rays were the gold standard, but we now know they have a massive, unacceptable false negative rate.
Why do plain x-rays miss so much?
Because of the physics of radiography. A myeloma clone has to destroy roughly 30 to 50% of the dense trabecular bone matrix in a specific area before that density change even becomes visible on a plain 2D x-ray. By the time you can clearly see a punched-out hole on an x-ray, the bone is practically hollow and on the verge of a catastrophic fracture. PCT and MRI are vastly more sensitive. They can identify the active, metabolically malignant lesions much earlier in the disease process. This fulfills the M in the SLIM criteria and allows you to intervene before the bone structurally fails.
Next pressure test. What is the absolute most common cause of acute kidney injury in a patient with multiple myeloma?
We hit this hard, but it's vital. It's cast nephropathy occurring in the distal convoluted tubules caused by the precipitation of filtered free light chains combining with TAM horsefall protein. Hypercalcemia is the second most common cause, as it induces severe renal vasoconstriction and nephrogenic diabetes insipidus, leading to profound dehydration, which ultimately exacerbates the cast formation.
Pressure test 3. I need to definitively diagnose AL amyloidosis. What is the gold standard phrase I am looking for in the pathology report?
You're looking for a tissue biopsy that demonstrates apple-green birefringence when viewed under polarized light microscopy after being stained with Congo red dye. Commit that exact phrase to your visual memory.
Pressure test 4. I have a patient with active myeloma. They have lytic bone lesions. I need to start a medication to inhibit the osteoclasts and stop the bone destruction. What is the drug class and what is the absolute vital prerequisite before I give it to them?
The first-line prophylactic therapies for myeloma bone disease are intravenous bisphosphonates, specifically zoledronic acid or pamidronate. Alternatively, you can use denosumab, which is an ARINC ligand inhibitor. However, the vital, highly testable prerequisite is that the patient must undergo a comprehensive professional dental evaluation. Any and all necessary invasive dental work like tooth extractions or root canals must be completely healed before you start these medications.
Why the focus on the teeth?
Because these specific drugs carry a rare but devastating risk of medication-related osteonecrosis of the jaw, or ONJ. If you administer zoledronic acid, you fundamentally paralyze the bone remodeling process. If that patient then goes to the dentist a month later and has a molar extracted, the jawbone physically cannot heal the socket. The bone tissue dies, becomes necrotic, and is left exposed in the oral cavity. It's incredibly painful, prone to severe infection, and notoriously difficult to manage surgically. You must secure dental clearance first.
Brilliant. Last pressure test for this section. When we diagnose a patient with multiple myeloma, how do we predict their mortality? What are the primary staging parameters?
The Revised International Staging System, or RISS, relies heavily on two simple, inexpensive serum blood tests: serum beta-2 microglobulin and serum albumin. Beta-2 microglobulin is a small protein that's normally shed by all nucleated cells in the body, but its levels rise astronomically in states of high plasma cell turnover and heavy tumor burden.
So a high beta-2 microglobulin is bad news.
Very bad news. A high serum beta-2 microglobulin coupled with a low serum albumin indicates highly aggressive, widespread systemic disease and carries a significantly poorer prognosis. The staging system also incorporates serum LDH lactate dehydrogenase as a marker of rapid cell turnover and specifically looks for high-risk cytogenetic abnormalities found on the bone marrow aspirate, such as the deletion of chromosome 17p, which knocks out the critical p53 tumor suppressor gene.
That perfectly covers the high-yield facts. Now, let's transition into discussing the clinical pearls and pitfalls. These are the subtle traps and the nuanced clinical scenarios where we see test takers and practicing clinicians trip up the most frequently.
And the number one pitfall, hands down, is misinterpreting the standard urinalysis in the primary care setting. We touched on this during the kidney vignette, but the underlying chemistry is so important it requires its own spotlight. Many excellent physicians operate under the assumption that if a standard rapid urine dipstick in the clinic reads negative or trace for protein, they have effectively ruled out myeloma kidney.
It seems logical. If the kidney is failing due to protein casts, the urine should be full of protein, right?
It is full of protein. But the standard urine dipstick uses a specific chemical reagent, usually a dye called tetrabromophenol blue. Because of its specific chemical properties, that dye is almost entirely sensitive only to the albumin molecule. It detects albumin beautifully, which is great for screening for diabetic nephropathy, but free light chains, which historically we refer to as Bence-Jones proteins, are structurally completely different from albumin. The chemical dye on the dipstick is completely blind to them.
So you could have a myeloma patient who's dumping 10 or 15 grams of pure toxic free light chains into their urine every single day, rapidly and irreversibly destroying their renal tubules, and the standard clinic dipstick will confidently read protein negative.
Exactly. You must look at the overall clinical picture and seek out the discrepancy. If the dipstick is negative or only trace for protein, but a quantitative test like a 24-hour urine collection or a spot urine protein to creatinine ratio shows massive amounts of total protein, you've uncovered a massive discrepancy. The dipstick says 0, the quantitative test says 5 grams. That missing protein is the free light chains. To identify them, you absolutely must order a UPEP, urine protein electrophoresis, and a urine immunofixation.
That's a life-saving pearl. Another area that consistently causes profound confusion is cryoglobulinemia. It's an intimidating $10 word. I know I used to constantly confuse cold agglutinins and cryoglobulins. Can we clarify the difference and then break down the different types of cryoglobulins?
It's a very common point of confusion because they both involve blood proteins acting abnormally when the patient is exposed to cold temperatures. But the mechanisms are fundamentally different. Cold agglutinins are actual functional antibodies, usually IgM, that physically bind to antigens on the surface of the patient's own red blood cells when the temperature drops in the extremities. This causes the red blood cells to clump together, or agglutinate, which leads to complement destruction and an autoimmune hemolytic anemia.
Okay, so cold agglutinins attack red blood cells. What do cryoglobulins do?
Cryoglobulins don't attack cells. They are immunoglobulins that physically undergo a phase change. They precipitate out of the liquid serum. They turn into a solid, cloudy gel when the blood temperature drops below 37 degrees Celsius, and they dissolve back into a liquid when the blood is rewarmed.
And the boards want us to know the different types of cryoglobulinemia, right?
Yes, the classification is critical because it points to the underlying disease. Type I cryoglobulinemia is composed of a single monoclonal immunoglobulin, almost always an IgM clone. Because it is purely monoclonal, type I is intrinsically linked to plasma cell dyscrasias and Waldenström macroglobulinemia.
How does it present clinically?
It causes symptoms through sheer physical obstruction. The monoclonal proteins gel up and physically occlude the microvasculature in the cold extremities. Patients present with severe renal phenomenon, digital cyanosis, livido-reticularis, and in severe cases, actual ischemic gangrene and necrosis of the fingers and toes.
That sounds horrific. But what about types 2 and 3?
Types 2 and 3 are classified as mixed cryoglobulinemias. They do not consist of a single clone. Rather, they involve a complex mixture of polyclonal IgG and monoclonal or polyclonal IgM. And this is the vital distinction. Mixed cryoglobulinemia is very rarely driven by a primary plasma cell disorder. It is overwhelmingly strongly associated with chronic hepatitis C viral infection or with systemic autoimmune connective tissue diseases like systemic lupus erythematosus or Sjogren's syndrome.
So the mechanism of damage is different.
Entirely different. Because they are mixed complexes, they act like immune complexes. They deposit in the walls of small blood vessels and trigger a massive inflammatory cascade, causing an immune complex vasculitis. These patients present with the classic triad of palpable purpura on the lower extremities, severe arthralgias, and progressive weakness. They also frequently develop membranoproliferative glomerulonephritis as the complexes deposit in the kidneys. So, the board shortcut. Type I equals a plasma cell disorder like Waldenström's. Types 2 and 3 equal hepatitis C or autoimmune disease. Keep them strictly separated in your mind.
Let's talk about situations where the standard algorithms and guidelines might lead you astray, or rather, where a test taker's instinct to be overly thorough and overtest might fail them.
We touched on this during the first vignette, but it's a classic recurring pitfall. Imagine a patient who strictly meets the criteria for low-risk MGUS. They have an IgG-M spike that's very small, less than 1.5 grams. Their serum-free light chain ratio is perfectly normal. Their CBC, calcium, and creatinine are totally normal, and they have no symptoms. The pitfall is the physician thinking, well, they have a clone. I still need to order a bone marrow biopsy just to be absolutely sure it isn't myeloma.
On a multiple-choice exam, the writers will always offer you bone marrow biopsy as an answer choice. You have to resist the urge to click it.
You must resist. In that specific, highly defined low-risk phenotype, Large-scale epidemiological studies have proven that the chance of actually finding 10% or more clonal plasma cells in the marrow is vanishingly infinitesimally low. The procedure is simply not medically indicated. You observe the patient with blood work. Do not cause unnecessary pain, anxiety, and potential bleeding complications by ordering an unindicated invasive procedure. Overtesting is punished on the boards.
And finally, for our pearls section, let's talk about those subtle one-word clues hidden in the text of board stems. The buzzwords that should instantly trigger a specific diagnosis in your mind, saving you precious minutes on the exam.
If you're reading a hematology stem and the pathologist report casually mentions rouleau formation, seen on the peripheral blood smear, your brain should instantly lock on to a plasma cell dyscrasia, or a high-protein state.
Rouleau is the French word for roll, right? Like a roll of coins.
Exactly. Normally, red blood cells possess a negative electrical surface charge called the zeta potential, which causes them to naturally repel each other. They float freely. But in myeloma or Waldenströms, the massive amount of monoclonal immunoglobulin circulating in the blood physically coats the red blood cells. This heavy protein coat neutralizes their negative charge. Without that repulsive force, the red blood cells stick together flat against each other, stacking up in long chains that look exactly like a roll of coins. It's a classic visual hallmark of hypergammaglobulinemia.
What about subtle physical exam findings?
If the clinical stem mentions a patient with heart failure or nephrotic syndrome, and then casually notes that they have pinch purpura on their arms or bruising around their eyes, raccoon eyes, after a coughing fit, the writers are practically screaming AL amyloidosis at you. Do not overlook those dermatological findings. In the context of an unexplained protein gap or heart failure, those physical signs are pathognomonic for amyloid vascular fragility.
This has been an incredibly deep and thorough exploration of the pathophysiology and the clinical reasoning. Let's lock all of this knowledge in. We're moving into our rapid board review takeaways. We're going to trade off 7 punchy, definitive rules that you absolutely must have committed to memory before you walk into the testing center.
I'll start us off. Rule number 1. If you see an older patient presenting with vague symptoms and their labs show an elevated total serum protein, a completely normal albumin, and an unexplained mild anemia, you must instantly think of multiple myeloma and actively look for the protein gap.
Rule number 2. Avoid doing standard skeletal surveys, plain X-rays, to evaluate for lytic bone lesions in suspected myeloma. Plain films miss far too much early architectural damage. The boards want you to select a whole-body PT-CT or a whole-body MRI as the most appropriate and sensitive initial imaging test.
Rule number 3. If you see a patient who strictly meets the numerical criteria for MGUS, a small M spike and less than 10% marrow involvement, but they present with unexplained severe acute kidney injury and nephrotic range proteinuria, think monoclonal gammopathy of renal significance or MGRS. You must biopsy the kidney to prove it, and then treat the patient aggressively with myeloma-directed therapy to save the organ.
Rule number 4. The absolute next best step for a patient with Waldenström macroglobulinemia presenting with altered mental status, blurry vision, and engorged retinal veins is emergent therapeutic apheresis plasmapheresis to physically remove the IgM from the blood. Do not administer rituximab first, as the resulting IgM flare will cause a catastrophic fatal spike in blood viscosity.
Rule number 5. Actively avoid administering intravenous contrast dye or prescribing NSAIDs to any patient with known multiple myeloma. These agents act as potent physiological triggers that drop the glomerular filtration rate, precipitating free light chains with TAM horsefall proteins and causing irreversible solid cast nephropathy.
Rule number 6. If you see a patient in a vignette who is initiating lenalidomide as part of their induction chemotherapy regimen for myeloma, the most appropriate next step in management is initiating low-dose aspirin or full anticoagulation. You must provide venous thromboembolism prophylaxis.
And rule number 7. If you encounter a patient with a solitary bone plasmacytoma, a single isolated tumor of plasma cells that has been successfully eradicated with local radiotherapy, the next best step is continued, lifelong surveillance. Despite being cured locally, these patients remain at an incredibly high risk for progressing to systemic multiple myeloma years down the line.
Excellent. We've covered the entire journey, from the idling engine in the driveway to the speeding car on the highway. To close us out, synthesize the single most important conceptual takeaway from this entire deep dive. If a listener remembers only one thing for their exam, what must it be?
If you take away only one core principle, it's the absolute, non-negotiable necessity of memorizing the precise quantitative diagnostic thresholds. The board exams do not deal in clinical vibes. They deal in hard, measurable data. You must know the numbers. 3.0 grams per deciliter for the M protein and 10% for the clonal bone marrow plasma cells. Those exact numbers form the rigid borders that separate watchful observation MGUS and smoldering myeloma from aggressive, life-altering chemotherapy. If you don't know the exact numbers, you fundamentally cannot safely manage the patient on the exam.
And I want to leave you with a final, slightly provocative clinical thought to mull over, extending beyond the multiple choice test and into your actual daily practice. We spent a significant amount of time discussing AL amyloidosis and how the misfolded light chains infiltrate the myocardium, causing heart failure with preserved ejection fraction, or HFpEF. The next time you're in clinic and you're seeing an older patient who has been slapped with the vague, frustrating label of idiopathic HFpEF, and they are just progressively worsening, completely unresponsive to standard loop diuretics and heart failure guidelines, I want you to ask yourself, could this actually be unrecognized amyloidosis? Are they secretly hiding a tiny malignant plasma cell clone that is slowly turning their heart to stone? It happens far, far more often in the real world than we care to admit.
It absolutely does. Maintaining a high index of suspicion is what saves lives.
Well, we've reached the end of the road for this incredibly complex topic. We warmly invite you to like this deep dive, subscribe to our feed, and please share this audio with any of your colleagues, residents, or fellows who are currently deep in their preparation for the ABIM.
You've absolutely got this. Trust your preparation, rely on your understanding of the deep pathophysiology, and keep those diagnostic criteria crystal clear in your mind.
Thank you so much for joining us as we unpack this today. Until next time, remember, even when the diagnostic waters are incredibly murky, a solid understanding of the physiological evidence will always lead you to the right answer. Take care.